Welcome to Editor's Choice, the podcast of Neurointervention, where we highlight the latest science and research in interventional cardiology. I'm your host, Aaysha Cader, and through conversations with the authors, we explore study design, key findings, and their relevance in contemporary practice. I'm very pleased to be joined today by Dr. Rick Volleberg and Professor Niels van Royen from Radboud University Medical Center in the Netherlands. And today we'll be discussing their paper on the long-term clinical outcomes of high-risk plaques with negative fractional flow reserve, the PECTUS-obs study. Welcome to the podcast, Dr. Volleberg and Professor Royen. So complete revascularization after MI and indeed how to be guided in the selection of non-culprit lesions to revascularize remains extremely topical. And in the PECTUS-obs study, you studied FFR negative, that is non-flow limiting non-culprit lesions by OCT, to define high-risk plaques that might drive recurrent events and have previously reported its 2-year MACE outcomes. Give us a bit of background to this study and why is it important to look at non-flow limiting high-risk plaques in non-culprit lesions?
Yes, so the PECTUS-obs study was initiated more than a decade ago. Actually, initially, it was an intervention study. So we planned to randomize patients to either optical medical therapy or optical medical therapy plus a bioabsorbable stent. But shortly after starting that trial, the absorb was retracted from the market. So we had to redesign our study. And we then realized that at that time, there were actually no good long-term follow-up data on OCT. So there were data for IVUS, for CT, but not for OCT. So then we came up with the design of the PECTUS-obs, in which we perform OCT in FFR negative non-culprit lesions in both STEMI and non-STEMI patients, and we did a 2-year as well as a 5-year clinical outcome. And why FFR negative lesions? Well, FFR in chronic coronary syndrome is, of course, a very solid parameter, but in acute coronary syndrome, there are some difficulties. So some technical difficulties to actually measure FFR in the right fashion. And that has to do with the hemodynamic milieu during the index event. But also with FFR, what you're trying to assess is whether a stenosis can cause ischemia. But that is less relevant in ACS. In ACS, what you're trying to predict is whether a lesion can cause a subsequent acute coronary syndrome. And that's where morphology comes in. And that's why you need additional modalities on top of FFR to assess that specific risk.
I think that's a very reasonable argument for doing this type of study. But before we move on to the results of this long-term follow-up, could you tell us briefly about the design of the PECTUS-obs study and what specific endpoints and additional analyses you undertook in this particular 5-year analysis?
So PECTUS-obs was a prospective observational study in which we enrolled 438 patients with STEMI or non-STEMI, and we performed OCT imaging on all FFR negative non-culprit lesions, which was defined as visually estimated stenosis grade of 30 to 90%. And what we excluded were patients with in-stent restenosis as a non-culprit lesion and those who only had lesions that were not imageable. So at 2 years, we looked at MACE. Then it was a composite of all-cause mortality, non-fatal MI, and unplanned revascularization. And now at the 5-year endpoint, we excluded non-cardiovascular death, periprocedural events, stent-related events, and indeterminate events. And the reason for that is that we believe that this revised endpoint more closely resembles the hypothesis of native plaque rupture and subsequent ACS.
And OCT images were analyzed by a blinded core lab. How was high-risk plaque defined by OCT criteria for your study?
So indeed, all images were analyzed by a blinded core lab, and a high-risk plaque was predefined in the presence of 2 out of 3 criteria, which is 1, a lipid arc of more than 90 degrees, 2, a minimum fibrous cap thickness below 65 microns, and 3, presence of either plaque rupture or thrombus. So that means that we both looked at TICFA, which is the combination of the first 2, as well as rupture or thrombus in co-presence of significant lipid.
In terms of results, could you outline the demographic and procedural characteristics and also any noteworthy differences in lesion level OCT features of high risk versus non-high risk plaques that you just described?
So among those 438 enrolled patients, 420 had at least one analyzable OCT, including 143 with at least one high-risk plaque and 277 without. The mean age of the population was 63 years, and approximately 80% of enrolled patients were male. And then we also included roughly equal numbers of patients with STEMI versus non-STEMI. If we look at traditional risk factors, there was no major difference between the groups. Non-culprit lesions were evaluated either during an index procedure in 1/3 of patients or during a stage procedure in 2/3, which was performed at a mean of 15 days after the index event. The evaluated lesions were mostly located in the LAD, 40% of cases, and then 30% of cases in the circumflex and another 30% in the right coronary artery. If we look at the lesion level, which was 154 for the patients for high-risk lesions and 340 non-high-risk lesions, the mean FFR was slightly lower in high-risk lesions at 0.88 compared to 0.90 in non-high-risk lesions. And correspondingly, the percentage area stenosis was larger, so 68 versus 64%. But those are minor differences, I would say. If we look at the plaque composition, not surprisingly, high-risk lesions were more lipid-rich and had more macrophage accumulation, while non-high-risk lesions were more calcified.
And what were the main endpoint results? Particularly, how did these compare with the 2-year outcomes that you previously reported?
So at 5 years, which was also the median duration of follow-up, only 4 patients were lost to follow-up, which means that follow-up was complete in 99.0% of patients. The patient-level endpoint of MACE occurred in 10.8% of patients without a high-risk plaque compared to 80.9% of patients with a high-risk plaque. This corresponds to a hazard ratio of approximately 1.87. This was driven by a significant increased risk of non-fatal MI with a hazard ratio of 4.00 and of unplanned revascularization with a hazard ratio of 1.97. And although we did not find a significant difference in cardiac mortality, the point estimate points towards a comparable risk associated with high-risk plaques. And these results are kind of similar to the 2-year outcome data, a hazard ratio of approximately 2.
And you also conducted multivariable and exploratory landmark analyses. Could you please elaborate on what these findings were?
2 multivariable analyses which showed consistent results. So the first one corrected for variables that we decided upfront to be associated with adverse outcome. And then the second was when we corrected for all variables associated with MACE in this study.
Yeah, with regard to the landmark analysis, so this was the 5-year follow-up, and we saw that at 5-year follow-up, the difference persisted. But at the same time, if you look at the curves, what you can see is that the big difference is made in the first 2 years. And then thereafter, the events still accumulate, but more or less to the same extent in both groups. And I think this can be explained by the fact that atherosclerosis itself is a very dynamic process. So it's not that you have ACS versus CCS patients, but a patient during his or her lifetime can transform from either a more vulnerable inflammatory state to a more stabilized state. So patients can be ACS patients at one point and then several later more CCS-like at a later point in time. And I think that is also what you can see in these curves. So during the index event, so in the period shortly after the index event, these patients are still in a more general vulnerable vascular state. So they have at different instances in their vascular tree regions that can still give rise to acute coronary events. And then over time, maybe because of the natural history of the disease, but of course also because medication that has been given after the index event, disease gets in a more stabilized phase.
It reflects the dynamicity of the acute phase and possibly the gradual stabilization later on. And this study is especially unique because it subselected non-flow limiting deferred non-culprit lesions to specifically demonstrate the importance of looking at high-risk plaque by OCT, which you clearly defined for us earlier. Do you reckon there'd be differences in prognostic implications based on different imaging modalities used, for example, IVUS, with relation to the aspects of plaque that they would focus on?
Yeah, that's a very good question. Unfortunately, we did not use different modalities in the same patients, of course, but there are some differences also with regard to what aspects of atherosclerosis you're assessing. So with OCT, especially the way we used it here, it's almost like a binary parameter. So you have or have not a high-risk plaque, and that can be in one singular frame. With IFAS, you can, of course, also assess plaque burden, plaque volume. The same you can do that with CT, and that might give a better prognostication of your longer term prognosis. And that has also been shown in other trials using those modalities. What I think is very promising there also for OCT is that there's now several algorithms by which you can use the complete pullback and all the information. So you can also do actual quantifications of volume-based parameters, so lipid volume, plaque volume, etc., also with OCT. So we still have to look into that, but I think by applying those kind of methodologies to OCT, you could also give a better long-term prognostication with this same modality.
Also, in the study, plaque rupture carried the strongest prognostic implication. What hypotheses do you reckon you can draw from this?
Well, this was a very interesting observation. So potentially the presence of rupture indicates somewhat of a systemic rupture proneness beyond the evaluated lesion. And as such, on a patient level, patients may be at an increased risk of developing events from spatially distinct lesions, but also on a lesion level. Another study recently published in Eurointervention by Zhao et colleagues, what they found is that the prognostic implications of plaque rupture were there, but however, if they corrected or adjusted for TICFA presence, it was no longer significant. So to me, that means that in those lesions that already have a ruptured cap, there is often another vulnerable spot, which makes these lesions still at an increased risk for recurrent events.
And in PECTUS-obs, of course, it is an observational study with important and very interesting findings. But what are some of the limitations you might caution when interpreting these results?
So first and foremost, the study was not powered to evaluate individual endpoints or lesion level events. Second, we only performed OCT on FFR negative lesions. So these were lesions that were angiographically visible. But we know from other studies that high-risk plaques may also be present even in absence of any stenosis on angiography. So we may have missed those high-risk lesions. And as just mentioned, we didn't evaluate variables such as plaque burden, unfortunately, because the OCT analysis were all performed manually, and there's no way to evaluate plaque burden manually due to the limited penetration depth of OCT. And lastly, although most patients were on high-intensity statin, few were on PCSK9 inhibitors, and cholesterol levels were not measured during follow-up.
And in fact, limitations to physiology-guided assessment of non-culprit lesions do exist, as we know from previous trials and data. And as demonstrated in this study and some others, there certainly appears to be a role for morphological assessment of non-culprit lesion plaques, particularly even the non-flow limiting ones. So the current evidence might suggest a complementary value of imaging and physiology for prognostication of NCL. What would you say future research in this space should be looking at?
So that's a good question. Well, I think if you would ask any interventional cardiologist, you're not gonna routinely use more than two modalities in the same patient. I mean, time-wise, money-wise, that doesn't seem realistic. So we will have to come up with ways how to select patients for using either of these modalities, but what we could also think of, and it's already actually available, is using your morphology to also assess physiology. So, of course, FFR angio is nowadays, you can still discuss on how accurate it is, but it is moving forward. But with OCT, you have, of course, the most accurate anatomic measures you can get. And from that, you can then also try to assess physiology, and it will never be as accurate as an actual invasive pressure or flow measurement, but I think you can get very close. And in the new Ultron software, for example, it is already available as OCT FFR. So maybe in the future, this is where we're heading at. And of course, what is also a very exciting field is non-invasive imaging. So the use of FFR CT nowadays, also with photon counting CT being even more precise and accurate. So I think that's where we're heading to. And then, of course, can we intervene? So if we have assessed these so-called high-risk plaques or high-risk patients, how should we treat them? Should we do additional stenting? Should we do more aggressive pharmacotherapy? So yeah, I think very exciting field and many new avenues ahead of us.
The jury's still out there on so many questions in the space of complete revasc of non-culprit lesions. Dr. Volleberg, Professor Royen, thank you very much for discussing your study on this podcast and also giving particular insights on how nuanced the assessment of non-culprit lesions is. Thank you.
Thank you.
Thank you.
Thank you for listening to Editor's Choice. To read the full article discussed in this episode, visit eurointervention.org. And if you've enjoyed this podcast, please subscribe to Editor's Choice for more conversations behind the science published in Eurointervention.